All right, Peter, it's me and you again. We are like, showing up every day here. We're
Yes, I'm
our
getting
own
used to
TV
this.
show. Well,
Well, we had this great presentation at the MDONS conference, and I'm working on a summary for that, and it happens to be just kind of the basics of breast cancer, taking people through. And I was just thinking about, I had this, I had the resources when I went with Julia for her diagnosis, for her, first couple of visits. I had this knowledge, and having that was such a, it was such a great thing for me to have. Just so I could understand,
right.
all the aspects of one, her diagnosis, and two, the treatment plan, and how the diagnosis relates to the treatment plan. So, when somebody gets a breast cancer diagnosis like you and Julia, it's like it's overwhelming. You have a lot of information in front of you. They probably give you some sheet which has a lot of jargon that you don't really understand, and you're still dealing with the whole shock of the whole diagnosis. So I thought it would be useful to just kind of run through. It's like you don't have to understand everything, but
Mhm.
it's just like the basics, just like the basics of a breast cancer diagnosis. So I thought that would be a great topic for us to just kind of go over today. We went over a little bit last week, but I think we could kind of dive into it a little bit more and really kind of understand. Maybe you could ask some questions that you had, when you first went for your diagnosis. Or
Absolutely. And again, if you're just jumping on here, you wonder who are these people? Well, most of you might, if you follow this show, you probably know that I'm usually here hosting, and Peter's usually in the comments. But Peter's also been on, a co-host for a lot of these now. And Peter is what I call him, our in-house scientist at Total Health. And so today we decided, as he said, we're going to just talk a little bit more about breast cancer. Peter, what are the most common type?
Well, yeah. First of all, the type of cancer that's most common. I'm just going to shut off my Slack here so that we don't get interrupted. But the one that's most common. There are other types, but invasive ductal carcinoma, which I'm pretty sure is what you had, and I know what Julia had as well. So
Yes.
that's going to be your most common type, most commonly observed.
Even when you said that word invasive, Peter, it still gives me shivers, and I'll tell you why. Because to a patient who's just hearing this, when they use the word invasive, you're thinking invasion, okay? And so you're thinking it has invaded your entire body.
Yeah.
And I wish doctors would just be a little bit more, God, a little bit more emotionally aware of when they're delivering this news. But when the woman called and said you have invasive, I'm like, what do you mean invasive? My husband was also like, what does invasion mean? But can you explain what invasive mean?
Well, invasive. There's a great picture from a presentation, but basically, if you think about the ducts, the breast is the ducts. And sometimes the tumor can be inside the duct, and it's localized to being inside the duct. I believe that's called ductal carcinoma in situ. But invasive ductal carcinoma means originating in the duct, but it has spread outside of the duct. So that from that perspective, I believe that's why they call it invasive. But yeah, Julia's actually, on when Julia went back for the diagnostic mammography, the person reading the sonography was like, "Oh, I suspect this is invasive ductal carcinoma." And it's like, that was kind of shocking to hear at that stage. It's like, don't you have to biopsy it first? So yeah, I could certainly relate to, hearing that word invasive and getting a lot of
Anxiety.
trauma and anxiety, as if you didn't have enough already from the diagnosis.
That's right. All right, let's talk about the options, right? And so you go to the doctor and they're saying lumpectomy, mastectomy, and I just want to say this too. When on the form about the lumpectomy, the pre-surgical form, it said partial mastectomy.
Yes,
I went to
yes.
the doctor. I thought you said this was going to be a mastectomy or whatever. She said,
Yeah.
"Yeah, but we call it that." I'm like, "I don't like that word. Can you change it back?" And she did.
Yeah.
You put it back to lumpectomy, like you told me. The partial mastectomy, I felt like I was going to come out of surgery and half my breast would be gone.
Yes,
So can
yes,
you just?
that's a very important point, and Julie was definitely wanting to point that out last week when I was on with her. She's like, "Yeah, don't be alarmed by that, but it does mean that a lumpectomy. What we're thinking about is you're removing the tumor only. You're not removing the whole breast. But I guess from a surgical semantics perspective, it's considered a partial mastectomy because you are removing some breast tissue. So don't freak out. I mean, a total mastectomy is where you're taking off the breast. A bilateral mastectomy is where you're taking off both breasts. So yes, that's something. Be aware of that. Is a lumpectomy, as we call it, is actually used to refer to a benign lesion being taken out of the breast without any breast tissue. I believe that's what a lumpectomy technically refers to in the surgical sense, but yeah. So yeah, don't be alarmed by the term partial mastectomy. But before we get to the surgical thing, I want to just they're usually going to do a biopsy on that whatever they find on the diagnostic ultrasound. And there's three key things that they're going to want to learn from that biopsy in breast cancer. And this is going to be done by a pathologist. They're going to measure whether your tumor is estrogen receptor positive, whether it's progesterone receptor positive, and whether it's positive for a molecule that we call human epidermal growth factor receptor 2 or HER2. Okay, so ER, estrogen receptor, PR, progesterone receptor, and HER2. So the two key things, first of all, are the estrogen and progesterone receptors. If your tumor has those, if it's positive for those, your tumor is considered hormone receptor positive. And we'll get into this a little bit later, but that means you are a candidate for endocrine therapy, okay? Anti-estrogen therapy. If your tumor is positive for HER2, that's a little different type of therapy that would also apply. That is treated with a drug called Herceptin. Many years ago, and it really it revolutionized the field of breast cancer. It was a very seminal finding when they found it to be effective in HER2 positive disease, because previously there was not a lot of treatment for HER2 positive disease. But that's a little bit less common. So what we'll talk about mostly today is the most common type, which is yours and Julia's type, which was ER positive, PR positive, and HER2 negative. Okay? So that I believe that was your tumor profile as well, right?
That's right. Yep.
So both of your tumors are hormone receptor positive. So that means you both were a candidate for anti-estrogen therapy or endocrine therapy.
Yes.
And all right, so then you would go for a surgical consult. And generally, for a tumor of that size, which I believe both of your tumors were. What the pathologist does, they will also grade the tumor at that point. They'll give an approximation of the size of the tumor, which I believe yours and Julia's were around 1 centimeter. Am I correct about that?
Yeah.
Yeah, so they will roughly grade the size. They will also do like a histological examination of that tumor tissue to determine, there's a thing called grade, which basically is a measure of the aggressiveness of the tumor. There's grade 1, which is the least aggressive, grade 3, which is the most aggressive, and then there's grade 2, which is kind of in the middle. It's called moderately differentiated. And actually, at the time, the pathologist graded Julia's as a grade 2. So we were like, well, it's not the worst, but it's also not the best either. So
Right.
that was a little traumatic as well when we got the pathology result. But then there's a separate thing that gets done. There's a separate classification and analysis of the tumor that gets done after the surgery. They're going to get much better assessment of the size of the tumor. They're also going to check the surrounding tissue or the margins, okay? Check to see if there's any cancer cells in there. So did they get it all?
Right.
And I'm not sure if you had this done, but I know Julia also had several lymph nodes.
Yes.
When she did the surgery. So they're going to check to see whether there's cancer cells in those lymph nodes. And if so, how many lymph nodes were positive?
Right.
The number that they took. So yeah, I believe that did they do that for you as well?
Yes, they did. You know, and I
thought in the axillary region. Right?
Yes. Yeah. Yep. And I think she said it was going to be 4. I'm like, why so much? You know, I'm like, how many do I have? You know.
Yeah. I mean, there's a whole bunch of them, but I think it's the ones that are in closest proximity to where the tumor tissue was taken from. So that would be the first place they'd go to.
Right.
If they were going to escape from that primary site, that would be the first place that they go to.
Yes. And she was explaining, of course, that the reason why they don't try one, they try a bunch in case they were traveling. They wanted to see how far they traveled to, you know, so they wanted to take out enough to see if there was anything. And, you know, but, you know, and again, these are just like kind of like scary things. And I remember she had told me they would be cutting 2 places, you know, they'd be cutting where the tumor is, then they'd be cutting where the nodes are. But for me, when I woke up from surgery, which by the way, I woke up on the operating table, which was really strange. I did. I'm like, why am I still in this room? But they said, well, they were able to just cut one place where the tumor was, and they were able to grab the other stuff that they needed from that one cut. So it cleared me an extra cut, which was good. But
Julia had an incision just right above her nipple, and there was also an incision over here, which is actually probably one of the more painful.
It's the worst one.
Yeah, that was one of the more painful things to heal. Yes.
Yeah, it's the worst one. I actually had a person reached out to me, a recent surgery person reached out to me to ask me, when does the pain stop? When does the pain stop? When does this?
Yeah, Julie's had a lot. Yeah.
And she hasn't had radiation. She hasn't had radiation. Yes. And I said to her, you just had surgery, you know, a month ago. If you tacked on radiation on top of that swelling, it takes a while. And the doctors had kind of warned me about that, Peter. And I don't know if Julia has the same, you know, issue, but they did warn me that the radiation effects will be there 2 years. 2 years. You know.
It has gotten better. I mean, you could probably Julia and she'd be able to tell you better, but you know, I know it has gotten better. You know, it's not 100%.
Right.
And you know, now that you kind of moved to radiation, I do want to discuss like another kind of a basic concept here, which is that adjuvant therapy.
Yeah. Yes.
So it's actually, you're thinking about first thing after surgery, you're thinking about they've already done all these analyses. There's 2 types of adjuvant therapy. Well, actually 3 types, but there's chemotherapy, there's endocrine therapy, which we talked about because you're hormone receptor positive. And then there's also radiotherapy. So let's talk about chemotherapy first. Chemotherapy, the purpose of adjuvant therapy overall is to, once you've taken that tumor out, once you've taken that piece of breast tumor out, you the surgeons are always confident that, hey, we got it all. The margins are clean. The lymph nodes are clean. We still want to ensure that there's no cells left behind. It's what we're do adjuvant therapy to eradicate what we call micrometastatic disease. That is, you know, like even one cell that escapes is a cell that can grow back later. So we want to eradicate any of those cells that might be left behind. And
Mm-hmm.
there's a couple of different ways we can do that. We can do it with chemotherapy, which is basically like poisoning the cells, actively growing cells,
Mm-hmm.
chemotherapy. There's endocrine therapy because that tumor cell is hormone receptor positive. We're going to starve it of estrogen that it needs to grow.
Mm-hmm.
And then there's radiotherapy, which
Mm-hmm.
is basically, again, it's attacking actively growing cells. It's oxidizing them. It's preventing them from growing.
Mm-hmm.
And chemotherapy obviously has a lot of toxic effects. We
Yeah.
know it will kill all rapidly dividing cells, like your hair cells. It
Yeah.
can cause your blood cells. You can reduce your immune system, your ability to fight infection. So it's a big gun that, everybody thinks about cancer. That's one thing that nobody wants to use. So if you can avoid using chemotherapy and doing that harm, you want to do that. So from that perspective, just talking about chemotherapy for now, there is a type of test. It's I don't want to use the word genetic test because that's something different, but I have referred to them as genomic classifiers. And basically what this does, there are a number of them available, but basically what that does is it investigates the genetics of the tumor cells. So that tumor sample that was taken out of your body,
Mm-hmm.
they're going to do this analysis. It's like a genetic analysis on this test. And some have like 21 genes, which is the ones that I believe you and Julia had. Some have more genes. Some of these tests are used more commonly than others, but the one that you and Julia had, there's a range of scores that you can get.
Mm-hmm.
And if you score very high, that means that your tumor has a very high likelihood to recur, to come back,
Yes.
and grow, not just as a local recurrence, but elsewhere in the body, which is what we definitely don't want. So in
Right.
that case, if you score high on those, if you score high on that genomic classifier, they're going to strongly recommend that you get chemotherapy.
Mm-hmm.
To kill any last rapidly dividing cells that got away.
Right. Right.
Okay? Now, thankfully, you and Julia scored low,
Mm-hmm.
meaning that chemotherapy, if you did decide to do it, would not be. It would provide so little benefit that it's not worth the additional harm that you would be doing to yourself.
Right.
By that they would be doing by giving you the chemotherapy itself, because as I said, it has all these adverse effects that you don't want. So thankfully, you and Julia scored low. You were able to safely avoid chemotherapy and did not have to do that. But if you had scored high, as I said, again, that your doctor probably would have referred you for a course of chemotherapy. Then that's done. And then you would move on in your treatment. And so that brings us to endocrine therapy.
Mm-hmm.
Now,
So some people have to do chemo and radiation. Why?
Yes. Well, again, both are adjuvant therapy. And the thing about doing we're going to call it a lumpectomy,
Mm-hmm.
or like the partial mastectomy, as we called it. Anytime you do that, that also requires a course of radiotherapy. And again, the goal is to get all of the remaining cells dead. So that was something that I didn't know. I didn't know that after you had surgery, you have to do radiation therapy as well. So Julia's course was fairly short. I mean, it was like, I believe it was 19 days.
Mm-hmm.
There were some breaks in there, so it wasn't like she was going every single day, but it's a significant time commitment. Yeah. But sometimes, I believe, I'm not sure, but sometimes if you did have to get chemotherapy, you would get chemotherapy, finish that, and then get radiotherapy. But I'm not exactly entirely sure of that.
Yeah.
Again, both of them, adjuvant therapy, the goal is the same, to get rid of any remaining cells.
Mm-hmm.
And actually, it has been shown that there's nothing that can say yet that you don't need adjuvant radiotherapy. It always seems to confer a benefit, across, for big tumors, for small tumors, for high-grade tumors, for low-grade tumors. There's nothing that they can say, oh, you could probably skip that. It always seems to confer a benefit.
So that's the reason why the doctor said before she did that genomic test that you're talking about, she said, you don't know what that's going to come back as, but I will tell you that you will need radiation.
Yes.
Yeah, because I was thinking maybe I could avoid that if they could just grab the thing and get it out. But she said, you may not need chemotherapy based on your scores. We'll see when it comes back, but you will definitely need radiation. So I'm going to send you to a radio oncologist and to consult. So that was like as you said, it was a not negotiable. I mean, I guess I could say no, but she was like, no.
Well, actually, there's in just the last a couple of meetings ago, there was some information about another genomic classifier type test that is not designed for chemotherapy. It's specifically designed for radiotherapy. Do you need it or not? And that seems to be able to show, it's not in use yet. I think it's still investigational, but that may be coming down the pike too, that we could say, maybe there are some people that could be spared radiotherapy as well.
Interesting.
Okay, I think I covered all the stuff about adjuvant therapy.
Well, one more thing on adjuvant therapy. The
endocrine therapy we got to get into, but go ahead. Ask your question.
It's an endocrine therapy because some people choose not to do that. Some people choose to do it, and of course we hear about the concerns of the side effects, which I remember. When I was being told to go on tamoxifen, I had family members saying, no, please don't do it because, of the side effects, right? That it creates cancer. So I'm thinking, why would something that supposedly help you with your breast cancer creating a cancer in your uterus, and cervix?
Yeah.
So then I said to my doctor, hey, my family, they're very uncomfortable with this. And he said, nah, you don't have to worry about it for two reasons. He said, I have a 95-year-old lady right here in the office right now going on tamoxifen. My first thought was 95? Oh my God.
Yeah.
Cancer is still around. I mean, I want to be like relaxing at 95. But then he also said, and I'm okay sharing this. He also said, I had a partial hysterectomy years ago. So he said, you don't have a uterus and these things that creates problem. So you don't have that risk factor. So he said, you're fine. You don't have that problem. So
I think it's uterine and endometrial cancers it's been associated with. Yes. Let me ask, what's the dose of tamoxifen that you're on? Do you remember?
20 milligrams.
So I believe that's full dose tamoxifen. There's another thing called baby tam now.
Yeah, it goes up to 40, he said.
Yeah. There's another thing called baby tam now. I think it's just like 5 mgs or something like that. But don't quote me on that.
Yeah.
But yeah, I have another summary from Lee Schwartzberg about that, talking about babies. But so going back to the genomic classifier, Julia had last week, she had her paper with her that gave all the information. But what it also does, besides telling you whether chemotherapy is going to be beneficial for you, it also gives you your risk of recurrence over a 10-year period. Yes.
So, excuse me, Peter, before you go on, Susan Strong is asking, even with a low score on that particular test, and the reason why we're not saying the test is because we don't want to say the test.
We're not endorsing any.
We're not endorsing. We're not, or not. We're not endorsing or not endorsing. So we don't want to relay the test. But for those of you who are, patients, you're probably familiar with the various tests. But Susan said, even with a low score, isn't chemo still needed with HER2?
I'm not entirely sure of that question. That's, but what we're talking about now is HER2 negative disease. And HER2 positive disease, you would be a candidate for a different type of treatment called Herceptin. But I don't know necessarily that chemo would or would not be indicated with HER2 positive if it were, say, a very small cancer. I'm not I'm not sure of that. I'm not a clinician, so I couldn't answer that question. But yes, here we're talking about HER2 negative disease, so we're not. And okay, so Julia, I believe Julia's risk for recurrence, and the risk for recurrence assumes that you take 5 years of endocrine therapy. Julia's risk of recurrence was 3%. And she had kind of already decided that she did not want to be on endocrine therapy for 5 years. So in that regard, by her not taking endocrine therapy, the risk would essentially double to 6%. So that's, and that was kind of her rationale. I mean, she was comfortable with that 94%. It's still a pretty good number. A 94% chance that you're going to be recurrence free at 10 years. That might not be,
Yeah, for some people it might not be. But I remember years ago when I was first getting my first, first mammograms, and when I was in the doctor's office, the number would be 85, right? Like, that is an 85% survival rate for cancer patients now, and this was years ago. And I thought, well, if anything ever were to happen, hey, the chances are pretty good that you'll make it. And then that number has gone up. When I was going through this, the doctor was telling me that number has gone up overall. I know there are disparities that we talk about with care and all the different factors, but all things being equal, with all the treatments and stuff, that number has gone up. And yes, as I mentioned when you were talking with Julia,
meaning the level is better up. Yes.
The numbers, better. They're talking about things like 95% and stuff, especially if you do stuff like radiation, they're like, it gets you to 95, 96. I remember the doctor saying to me, like Julia, we can give you a short course, like 15 or 16 days of it, right? And if we give you any more than that, you're only going to potentially get another 1%. So, but the damage might be too much. So I'm like, no, don't bother with that. The 1%, I live with whatever, So like Julia, on the radiation side, I'm like, yeah, we'll keep it to the 15 limited, the 2-minute pops. The endocrine therapy, now most recently, Peter, my oncologist retired, and then a new one came on the scene, and she said to me, you're on tamoxifen, which is fine, but it's usually for women under 50. She said it can work for you too, over 50.
Premenopausal women, it's usually used.
Yes. And she said, but the one that I think you should switch to is anastrozole.
Right.
It's showing that it has better benefits for you. So it doesn't have the tamoxifen risks, I guess, for the uterine and stuff. But she said it does have a bone risk.
Yes.
It has a bone risk. What do you know about that? Do you know anything about that?
So tamoxifen is what's called a selective estrogen receptor modulator. So it's working on the estrogen receptor itself. What anastrozole is, and there's two other drugs, letrozole and exemestane. What those three drugs, the latter three drugs are aromatase inhibitors.
Yes. What is that?
In postmenopausal women, you're no longer producing estrogen because you're in menopause, right? But you can still create estrogen by metabolizing peripheral androgens to estrogen. So what the aromatase inhibitors, as they called, or AIs, they inhibit this process, so further reduces your estrogen levels. That's
I see.
So that, yes, I'm now why you were on tamoxifen initially and why she wants you to switch. I'm not exactly sure of that. But
she said it's doctor's choice. She said it's oncologist's choice.
Yeah.
And she's a Harvard educated doctor. And right before I relocated from North Carolina to Florida, she was going to switch me. She had me think about it for 2 weeks. I spoke to Sarah, of course. I'm like, what do you know about this? And Sarah said what she heard was that there's a great benefit of being on tamoxifen for 2 years and then switching at year 2 to anastrozole, that there was like even improved benefits. So the doctor said, I don't want to switch you as you're leaving the state. When you get to the new doctor, let him know about our conversation and see what he says. But I did some research too, and she said we can work with bone. So we can do things to work with your bone, and not everyone has a really bad bone response. But if you do, we can do stuff to work with that. But it has
if you're starting out with, you know, pretty low bone density, or you have a history of osteopenia or anything like that, you know, you may want to reconsider, you know, using aromatase, because like anything else, they do have side effects.
Yes.
And, you know, bone fracture is it's a huge issue.
Yes.
So you do have to monitor your bone health, and sometimes they'll use what's called a bisphosphonate, which it inhibits the resorption of bone, so it prevents the breakdown of bone. So that's another treatment that they could give you in addition to at the same time when you're taking the aromatase inhibitor to prevent that. To prevent that bone loss. And actually, I think it also reduces risk of breast cancer recurrence, interestingly enough.
You mean that other bone thing?
Yes, the bisphosphonate therapy, yes.
Yeah. So I'm actually leaning towards it, because when I did the research myself, I thought I could see why the aromatase inhibitor would probably be better for me. And the doctor did do a hormone test for estrogen, and she's like, you know, you're really not producing anything, you know, because I mean I'm at a certain age. All right, I know that Susan's asking in regards to genomic testing. With Susan, if you could clarify that, Susan. As Peter said, we're more talking about the HER2 negative cancers today. We'll come back again with an expert on the HER2 positive cancer, and hopefully we can answer those questions. Again, we're not trying to give medical advice on this show. Not. Peter's wife and myself were both, you know, breast cancer survivors, and we had similar breast cancer. She was at stage 2, I was at stage 1, but we kind of had a similar path. And, you know, just, you know, our different options.
I just wanted to kind of give the basics of what you should know about your breast cancer, questions you should ask, and how that relates, how those findings, you know, the estrogen, progesterone receptor, HER2 receptor positivity, how that's going to impact your treatment, and the value and the importance of adjuvant treatment.
We had more questions, Peter, but I know time doesn't allow us 33, and I want to ask this one last one. So there is like a debate, right, on how long you should remain on these endocrine therapies. Some doctors say 5, some say 7, some say
standard therapy is 5 years.
5 years. Okay. All right. 5 years.
5 years tamoxifen, 5 years, or if you're postmenopausal, 5 years of the aromatase inhibitors. To my knowledge, that's current standard. And in some cases, they do, you know, if a person has very high risk breast cancer, a very high risk for recurrence, they do what's called extended adjuvant therapy, which I believe extends that 5 years out to 10 years.
I see.
And, you know, generally speaking, compliance with endocrine therapy is very poor because women do not like the side effects. You know, I'm sure if you Google, you know, side effects, you'll be very put off. I'm sure you probably have.
I did.
Julia just wanted no part of taking pills for 5 years.
Yeah.
That was, you know, she was comfortable with that 3% risk going to a 6% risk by making that decision. And, you know, she's also getting the benefit of not having the side effects.
Right.
The aromatase inhibitors, which she would have been on.
Right, exactly. You know, I'm grateful that on the tamoxifen, for me personally, again, for me.
How long have you been on it? How long have you been on?
Maybe about 15 months. And for me, the only side effect that I can physically feel is literally 15 minutes after swallowing that pill, I'm hot for about 15 minutes, and then I'm not. But that's been it. I don't have the fatigue. I don't have a lot of them that I see online. I don't have.
I believe it does have some positive cardiovascular effects, if I'm not mistaken. Yes.
Not just that, it has tamoxifen lowers your cholesterol.
Yes. Yes.
My doctor, to be honest with you, Peter, I was actually on cholesterol meds, a low dose, for about 4 years now, 5 years now, because the oatmeal wasn't working. Anyway, with the tamoxifen, it took me off it because my cholesterol is so perfect. So
drawbacks.
yeah, so I was, tamoxifen says, it improves your numbers, and I can tell you, I got off atorvastatin. So
yeah. So I'm sure probably you'll review this with your doctor at at your 5-year mark.
Yes, Sarah mentioned this test called a BCP test. I don't know if you know much about it, but we won't go into it today. We'll come back to it. But she said, I want you to get that BCP test.
BCI test.
BC what? Some test.
Could be BCI, breast cancer index.
Yes, could be that. Yes.
Yeah, that's probably a story for another day. But I think we are low on time. But that I believe is used. Well, I know is used to determine the need for extending adjuvant therapy.
That's right. That's right. That's right.
You still got your 5 years to get through. So if you decide to continue for 5 years, but I'm sure your oncologist will go over that with you when you reach that 5-year mark, and I'm sure you will.
Yes. Susan says, in regards to genomic testing, Susan, I still think that we are not probably equipped today to answer the question on the HER2 as to why they still need chemo. So we will leave that conversation. But Peter, thank you so much for chatting with me about that. I learned a lot just working at Total Health.
Hopefully, it gives some information to people. Get a little bit more. As I said, you don't need to understand all of it, but just the basics.
It is important.
And understand why you're receiving.
Yes.
And like we always like to end on a positive note. We hope we can educate people, and by educating, we can empower.
That's right. That's the mission of Total Health. An educated patient. I think you help to save your own life, really. All right, Peter. I think we have on Monday. I think I have a doctor, my integrated.
You wanted to get into this. I think we should definitely bark that out. That's going to be a great talk. I would look forward to that one.
Yes. And she's also a breast cancer survivor.
Great. So I think she would have a great perspective on this too. I'm really looking forward to that.
Absolutely. All right, guys. We'll see you guys on Monday. Have a great week. Bye.